Hello, everyone. Welcome to the Network Physiology webinar series. My name is Alireza Mani, and I'm one of the organizers of a series of webinars on the emerging field of network physiology. This is our fourth session of the series, which is dedicated to the network physiology of the liver. This session will feature two talks, with each talk lasting approximately 25 minutes. After the second talk, we will have a question and answer like previous sessions we had on this series. I would like to thank the speakers who accepted our invitation, and also the Physiological Society for making this event possible. My colleague, Dr. Tope Oyelade, is another organizer of the series. Tope, would you like to say a few words?
Thank you very much, Alireza, for that general introduction as usual. Again, as usual, I'll go through some of the housekeeping instructions. Please be aware that this webinar is being recorded for the purpose of publishing it in future, for future reference. I will kindly ask you all to keep your microphones and video cameras off for the duration of the meeting. And then, of course, please submit any questions through the chat. Questions can be typed at any time during the presentation. All questions would then be directed to the speakers and chairs during the Q&A session, which will come at the end of the talk. Thank you very much.
That's perfect. Thank you very much. So our first speaker is Professor Sara Montagnese, and it's my really pleasure to introduce Sara to you. So Professor Sara Montagnese is the chair of medicine at the University of Padova and also a professor of chronobiology at the University of Surrey in the UK. Sara studied medicine at the University of Padova and then specialized in internal medicine and hepatology. She also holds a PhD from University College London. Sara has a long-lasting clinical and research interest in hepatic encephalopathy, on which she has published numerously. She has published excellent papers, especially on diagnosis and differential diagnosis. She's the past president of the International Society for Hepatic Encephalopathy and Nitrogen Metabolism, ISHN. And she's currently serving as the vice president and the president-elect of the European Biological Rhythm Society. Sara's research has also focused on sleep-wake disturbances in patients with liver disease, where she has made significant contribution to understanding diagnosis and treatment. Very impressive research on chronobiology. She is now applying her expertise in liver disease as a model for broader application in medicine. In addition, she is actively working on the management of hospitalization-related sleep-wake abnormalities and development of patient-specific tools for circadian assessment. So on a personal note, I have learned so much from Sara through our collaborations. She's a wonderful clinician scientist, also a wonderful friend and collaborator. Her dedication and vision in medical research, clarity and integrity in both clinical and academic work make her an outstanding clinician scientist and colleague. So I can talk about Sara for hours and hours and hours, but of course you don't want to listen to me, you want to listen to Sara. I'm delighted to invite Sara to speak on multi-system involvement in liver cirrhosis. Thank you very much, Sara.
So good afternoon. Thank you very much for much appreciated invitation and this very generous and kind introduction. Great pleasure to be here this afternoon. So here we go. Let's see if I can make it bigger. So I am going to talk to you about cirrhosis of the liver as a multisystemic disease. Cirrhosis of the liver is not a very common disorder. It has a prevalence of approximately 1 per 1,000, which is a fairly difficult number to obtain for a number of reasons. From a point of view of its definition, cirrhosis is defined histopathologically. So it is the features of the liver, to begin with on biopsy, these days mostly on imaging. And the histopathology of cirrhosis is extensive fibrosis and the presence of regenerative nodules. When I studied medicine, cirrhosis was chronic, and it still is, and irreversible. Our idea about the reversibility or otherwise of cirrhosis has changed in recent years. And there is proof, there was at some stage some enthusiasm. This is a video you can watch on Nature about tipping the balance between reversibility and irreversibility in cirrhosis. and eradication of viral hepatitis, abolition of alcohol misuse can actually lead not only to a stabilization of the disease, but sometimes to some degree of reversibility of the fibrosis and even cirrhosis itself. Ultimately, regardless of what has caused cirrhosis, you get cirrhosis because of hepatic necrosis due to chronic liver pathology, which can depend on a variety of different reasons, some very common, some less common. This is what a healthy liver looks like on a picture, and this is what it looks like on histology. And in terms of the way that the liver suffers from chronic insults, this is what I'm going to talk to you about this afternoon. I'll talk very little about acute and acute on chronic liver disease. I'll talk about chronic liver disease. And the way the liver gets unhealthy is by deposition of fat. All of you will have heard about fatty liver. Steatohepatitis is the simultaneous presence of both fat and inflammation. Then there's acute hepatitis, which is most commonly viral, and chronic hepatitis. Ultimately, all of these, over different periods of time and to some extent through different pathophysiological mechanisms, produce some degree of fibrosis. And when fibrosis is extensive, it is called cirrhosis. Cirrhosis is now a term only applied to the liver, but it used to be applied to extensive fibrosis of several other organs. So it really means that the whole of the liver, of most of it, is fibrotic. On top of all that, what can happen is one can also get primary liver cancer, the most common form of which being hepatocellular carcinoma. This is a fairly interesting feature in the sense that most primary cancers of other organs do not require the organ to be diseased in the first place. Hepatocellular carcinoma is very rare on non-cirrhotic livers, with the exception of fatty liver and steatohepatitis, on which it can appear before the organ is extensively damaged. In terms of the reasons one can get cirrhosis, the most common are chronic viral hepatitis, the most common of which being hepatitis B and hepatitis C, alcohol misuse, autoimmunities, drugs and toxic substances. There are a number of forms of metabolic cirrhosis, the most common being non-alcoholic steatosis and steatohepatitis, so fatty liver and fat and inflammation, which due to metabolic syndrome, overweight, hypertension, diabetes becoming very common in the Western world, is becoming very, very much more common than it used to be. And then there are slightly more exotic reasons like chronic cholestasis, hepatic vein obstructions. When we don't know where it came from, we call it cryptogenic, which often means we haven't been very good at taking medical history. The interesting thing about cirrhosis is that being a histopathological or an imaging diagnosis, you can have perfectly compensated cirrhosis. Some patients, not many, but some, do come to clinic having performed, for example, having undergone an abdominal ultrasound for entirely different reasons, and being told that their liver is small and looking hardened and having a number of imaging features suggesting the presence of advanced chronic liver disease. Other individuals can present with considerably more dramatic forms of liver disease, with enormous amount of fluid accumulating in their abdomen, sometimes in their legs, bruising, jaundice, malnutrition, not as common these days, although malnutrition by excess is also common in these patients these days. And this happens when cirrhosis decompensate, when you get acute liver failure, and sometimes when you get a sort of a mixture of those two, which is called acute on chronic liver failure. The likelihood, if you have compensated cirrhosis, of your evolving towards decompensated cirrhosis and developing these fairly traumatic forms of disease is estimated at 5 to 7% a year. The average survival of a cirrhotic who has a compensated cirrhosis is 12 years. the average survival of a decompensated cirrhotic is 2 years. Compensated cirrhosis, I would say, is liver disease. Decompensated cirrhosis, for sure, is a systemic disease. I'll try to show you why, simply by descriptive means, and more often than not requires multidisciplinary management. Instead of going forward in disease, you can go backwards. As I mentioned, fibrosis can revert and decompensation can turn into compensation. This very much depends on etiology. For the most common reason for transitioning from decompensated to compensated is alcohol misuse being stopped, but also viral eradication and various other interventions can help stabilizing patients who were previously decompensated. When you decompensate, you can go 2 ways. You can have features of what's called portal hypertension or features of what's called hepatic failure. These are very different from a clinical standpoint, from a prognostic standpoint. And I find it extraordinarily interesting that they were first described by Sheila Sherlock, who is the person who somewhat invented hepatology as a clinical branch, as a specialization, and published on The Lancet in 1948 on a case series of 9 patients. In order to learn this much from 9 patients, you have to be good. But probably the clinical picture also has to be pretty dramatic. So she had 9 patients who had had hepatitis, and she followed up for a number of years. And she concluded, you can look at the summary on your right-hand side, that in 3 patients, the lesion, the hepatic lesion was very well compensated and basically had no symptoms, no physical signs, and virtually no biochemical changes. In 2 patients, and this is hepatic failure, hepatic cell necrosis and degeneration were prominent. These people were jaundiced, and they had abnormalities in most liver function tests. And 4 patients, these are the people who developed portal hypertension, the signs and symptoms were those of portal circulatory obstruction. Biochemical changes were slight or absent, and 2 patients died of gastrointestinal bleeding. This couldn't have been a better description of what we still see these days and the way we sort of describe the natural history of the disease. So portal hypertension is literally an increased pressure in the portal vein, which is one of the vessels that brings blood into the liver. Contrary to what is common perception, a cirrhotic liver is a small, hardened, fibrotic organ, and therefore blood has trouble getting into this kind of stony liver that these people have. So there's increased resistance to portal flow. And also there is another phenomenon, which is there is more blood in the abdomen and in the splanchnic vessels anyway. So these 2 phenomena result in an increased pressure. I don't know if you can see my pointer, in the vessels that bring blood into the liver. And this, of course, results in a whole set of consequences in the organs, in the skin, in the vessels that are behind, in terms of pressure and circulation, those directing blood to the liver. This results, for example, in the development of ascites, which is what I have shown you before, in very obvious collaterals that shunt to some extent the liver and become very visible on the walls, the abdominal walls of these patients, because the blood having trouble forcing itself through the liver takes other ways. And the most dangerous, possibly, complication of portal hypertension, which is the presence of esophageal varices. So some of these bloods fills the so-called coronary vein, and blood pressure increases in the veins, both in the stomach, but especially in the esophagus. This is a picture of the esophagus taken from an OGD, a gastroscopy. So you're looking at the organ as the scope goes in, so from the top of the patient, from the mouth of the patient into the esophagus. And the esophagus, instead of being patent, open, you can see these big blobs, which are not unlike those you can see on the legs of people who have venostasis, which are called esophageal varices. This is a very dangerous situation, and it was a very prominent cause of mortality when Sherlock started in 48, and when I also started many decades down the line. Now we have become considerably better at managing and treating this problem, which we do with hemodynamic and vasoactive substances when bleeding is occurring, but we mostly do by preventing bleeding, either pharmacologically or with some interventional maneuvers. When people bleed from esophageal varices, they of course need an urgent gastroscopy, and here you can see, of course, a different patient with one of the varices having bled. Of course, the operational area is very complicated. In this situation, it's difficult to see and it's difficult to work. And one can either try to ligate these vessels or glue them. But the best proposition these days is to try and prevent bleeding, either with medication or by ligating in what is called the setting of primary prophylaxis, so before the first bleed has occurred. And in this respect, management has improved considerably over the past 20, 25 years. We see much less of these extreme situations these days than we did 15, 20 years ago. Another thing that one can do if a patient is bleeding from the varices is called TIPS. This is something that interventional radiologists or hepatologists do, and TIPS stands for transjugular intrahepatic portal systemic shunt. So what one does is inserting this tube, starting from the jugular vein and going down through the hepatic vein, connecting them to one of the big branches of the portal vein. So this way, of course, the pressure, which is very high here when the liver is cirrhotic, fibrotic, and hardened, decreases very rapidly because a significant amount of blood is shunted through this tube and on the outflow of the liver, and therefore it is relatively easy to stop the bleeding. Another consequence of portal hypertension is the development of ascites. The development of ascites depends on portal hypertension, on sodium retention. It depends on the fact that the liver produces albumin, which is primarily responsible for oncotic pressure, and therefore low albumin also favors the situation. Flanking vasodilation, which I mentioned before, and lymph formation around the liver and the spleen. Again, this can be managed with hygienic measures or pharmacological measures, fluid restriction, albumin, which works very well, diuretics, or a sort of medieval looking intervention, which is called paracentesis, and we still do on a daily basis in our wards and in our day hospitals, which is paracentesis. Paracentesis is simply the introduction of a big needle into the abdomen and the evacuation of ascites. This can be done for diagnostic purposes, so to study the features of the fluid, but also to relieve the patient in the first place from abdominal tension and also from difficulties breathing. Paracentesis can also be used when the patient tolerates pharmacological interventions badly. And this is again another problem, because most of things we do to relieve ascites make the kidney suffer. You can see how I'm moving around the body with one disease, which is cirrhosis, from one organ to the next, really suggesting what Professor Mani was mentioning before and what this whole section is about, which is liver failure being a multisystemic disorder. So there are a number of reasons for which the kidney tends to suffer in advanced liver disease. This is a very famous picture. It's an angiogram of a kidney. It's a type of radiological imaging that we use very little these days because it can be quite dangerous, and there are better and easier ways to look at the kidneys. But this is an unfortunate patient who died when they were undergoing the angiogram. And this is what we can see of their kidney when they were still alive. And the minute they die, you can see this kidney getting filled with blood and being much more obvious on the imaging, suggesting and in some ways proving that a significant proportion of the suffering of the kidney in patients with advanced liver disease is functional. So it's not tubular necrosis, it's not structural damage of the kidney, but it's insufficient inflow of blood, which is why at least part of this complication can often be corrected with albumin and with fluids. I won't have time to go into this, but in the same way as there's a syndrome which is associated with advanced liver disease, which is called hepatorenal syndrome, there is also a hepatopulmonary syndrome, which is an interesting situation, one of the very few situations where platypnea exists, so people breathe better when they are lying rather than when they are sitting up or standing. And more recently formalized, there is also a hepatoadrenal syndrome. So again, one organ structurally damaged, many organs suffering. So I've told you that ascites is difficult to measure pharmacologically. Paracentesis is not pleasant. Again, like I've shown you for variceal bleeding, ascites can be managed by TIPS. However, TIPS has complications. So while if a patient is bleeding, one is more than happy to put in a TIPS because the risk of death is very high. So there's not much hesitation. If a patient has ascites that is not responding to pharmacological maneuvers or paracentesis are becoming too often, we can also use TIPS. But here we think about it a lot more and a lot longer. Because a patient for whom we put in a TIPS may be put in a situation whereby they no longer suffer from ascites, but they suffer from a different complication of liver disease, which is also evoked by TIPS. And this is my favorite complication of liver disease, which is what I study, which is called hepatic encephalopathy. Professor Mani has mentioned that I study the liver and I study the brain and I study sleep. And many people, when I tell them I do this, they say, oh, why? What's the connection between the liver and the brain? And there is a lot of connections between the liver and the brain, because what happens in normal conditions is blood from the gut and from other abdominal viscera gets into the liver, which is healthy, detoxifies this blood. Some of the substances are then excreted via the biliary system. Clean blood comes out of the liver, gets into the heart and in the systemic circulation. When you have advanced liver disease, two things happen. Well, first of all, the liver is not detoxifying intestinal blood with the same efficiency as a healthy liver does. So liver failure by itself determines some degree of toxin and neurotoxin remaining in the outflow from the liver, getting into the heart and into the systemic circulation and the brain. Plus portal hypertension itself, so the fact that there is a resistance to blood inflow into the liver, determines the formation of what are called collaterals or portal systemic shunts. So some of the blood shunts or skips the liver altogether and gets directly into the systemic circulation and into the brain. So the combination of hepatic failure and portal systemic shunting creates the possibility of neurotoxin substances of intestinal origin, essentially, the most commonly known being ammonia, which reach the heart, reach the systemic circulation, and cause a syndrome which can be of irritability, slowing, up to what's called hepatic coma. This is largely reversible and also deeply affects sleep, the sleep-wake cycle. So these individuals, especially those with severe encephalopathy, can be wide awake at night and tend to be sleepy and dysfunctional in the day, which of course heavily impinges on their quality of life. If ever anyone has any doubt about the existence of what is called a gut-liver axis, a gut-brain axis, I think liver disease is really the proof that this exists, because one of the situations when patients with advanced liver disease get hepatic encephalopathy is constipation. Because of course, constipation creates a situation whereby the flow of neurotoxins into the liver and the systemic circulation is favored by the fact that they are not eliminated by the intestine. And when hepatic encephalopathy is precipitated by constipation, it can be easily resolved by an enema. And patients who are actually very sleepy, if not comatose, can rapidly, in a matter of 12, 24, 36 hours, become well with this simple maneuver. So if you had a doubting mind about the existence of the gut-brain axis, you can read about the features of these disorders, and I'll think you'll get convinced. The liver also produces coagulation disturbances because the liver produces coagulation factors. For many, many years, the only concern we had as hepatologists was bleeding. Of course, because we were also much worse at handling gastrointestinal and variceal bleeding. These days, we are not so worried about the liver being a pro-hemorrhagic condition when it is disease, but we believe that in liver patients, there is a relative deficiency of both procoagulants and anticoagulants. So what the liver is doing in this situation is making the balance much more complicated. So much so that there are situations, complications of advanced liver disease, especially a condition called portal vein thrombosis, whereby since 2012, this was a major study in gastroenterology and hepatology, we have started using anticoagulants in these patients. So again, a disease that structurally affects the liver that can either favor or disfavor bleeding and coagulation. And finally, hepatocellular carcinoma. This is probably the most kind of liver-related complication of advanced liver disease. Here you can see a picture, for those of you who are not familiar with it, of a liver ultrasound. This is the liver. And here you can see a relatively big mass, which can be measured. These are measurers on ultrasound machines. And this is a different way of imaging. This is an abdominal CT. So in this situation, you're seeing a picture of a patient cut from their umbilicus towards their back, and you are looking at them from the top of their head. So this is the vertebra, this is the aorta, this is the liver, which can be recognized in its unmistakable shape, and this is a big liver mass. So you can have so much of these complications in different proportions related to portal hypertension and hepatic failure that you may end up needing liver transplantation. Liver transplantation is now become fairly common procedure. In Padova, which is a big liver transplant center, we do between 100 and 150 per year. And it's easier these days in most European countries to have livers available. This is just like a historical picture. This is Tom Stargell, the first transplant surgeon to ever transplant the liver, and many other achievements. Between 62 and 63, he dealt with pharmacological management of allogenic kidney transplant. In 63, he performed the first liver transplant. In 67, the first successful liver transplant. In 89, he introduced tacrolimus to combat organ rejection. So, you know, a big medical career. And if you want to read about his story and his achievements and his struggles, you can read this book, which was suggested to me by Professor Mani, which is called The Puzzle People, Memories of a Transplant Surgeon. So whichever way you get to it, and whoever is going to perform it on you, by the time you get to the need for liver transplantation, you either need it these days for hepatocellular carcinoma. We transplant a lot for hepatocellular carcinoma, or you need it because your liver function is so compromised that you can't really recuperate it in any way. At the beginning of the transplantation era, which was not that many decades ago on a large scale, the principle was the seeker, the most favor on the transplant list. So the higher your liver dysfunction scores, the more likely you were to receive a transplant. Of course, nowadays we know that you reach a level of futility, so you can be so sick that you won't benefit from the transplant. And it has become much more complicated to put and especially order individuals on a transplant. But the first tool ever to be used, which was the most commonly used index of liver failure, was the so-called Child-Pugh score. And the Child-Pugh score used to evaluate the severity of liver disease with a number of indices, which you can see are its cerebral complication, the presence of fluid in the abdomen, bilirubin, which is what causes jaundice, albumin, which is produced by the liver, prothrombin time, which is a coagulation index. This is a special exception for one type of cirrhosis. And in the old original version of the score, which used to be called Child-Turcotte, there was even a parameter called nutritional status. If you remember the picture of the very sick patients that I showed you, you could see that they had very limited muscle mass. And I still strongly believe that malnutrition by defect and muscle mass deficiency is a complication, and it's not an association to liver failure. And it was only removed from this point system because it was thought to be too operator dependent. And ultimately, also the Child-Pugh score at some stage was dropped from selection transplantation because it was thought to be too operator dependent. Because of course, encephalopathy was graded clinically, ascites was graded clinically. So there was somebody's intervention that could somewhat impinge on the total score. So nowadays we use different scores, which are entirely based either on anthropometric indices or on laboratory indices. The MELD score, which is based on creatinine, which is, one could argue, an index of kidney function. Again, bilirubin and the INR. MELD sodium, which performs better than MELD, and which is MELD with sodium as a top-up. One wouldn't necessarily think of plasma sodium as an index of liver disease. And the more recently introduced MELD-3, which also takes into account of sex and albumin levels. So are we going back to the Child-Pugh score? Of course, none of the above takes into account of encephalopathy, so much so that there has been proposal of either using it clinically or on our part with a quantitative index of brain dysfunction, which, however, is not very commonly measured. So these indexes haven't become common. Either way, by the time somebody starts thinking of giving you a liver transplant, you get to one of these lists, and the people who discuss your suitability and your potential order on the transplant list are hepatologists, who can be gastroenterologists or internists like me. Of course, the hepatobiliary surgeons, who ultimately will transplant you, an anesthetist, a radiologist, more often than not an oncologist, and psychologists. Once you've had a liver transplant, you are more than likely, on top of all those, to also need diabetologists, endocrinologists, dermatologists, especially in the long run, and once you've had immunosuppressive treatment for a number of years. So again, even from the point of view of its management, and even from the point of view of the complication of its replacement, liver failure and chronic liver failure are multisystemic diseases. The reason why I think it is absolutely fantastic, and it is crucial to have this type of meeting and to have scientists like Tope and Ali working on different, somewhat non-clinical ways of addressing these issues, is because if today we have, of course, become much, much better at managing the 9 patients that are in Sherlock's paper in 1948. But if I were to receive 9 patients, the same as Sherlock did, I may be able to tell apart the 3 that would die quickly and would develop acute liver failure. But out of those who'd be well and those who develop portal hypertension, I wouldn't really be able to tell apart. So our current ability to prognose in individuals on cirrhosis diagnosis in terms of the way their liver disease will develop and ultimately the way their overall history will develop remains fairly poor, and we remain substantially unable to put together relevant clinical elements of this multisystemic disease to prognosticate and to make clinical decisions. Thank you very much for your attention.
Amazing. Thank you very much, Professor Montagnese. I really enjoyed you. Every time I listen to you, I learned something new. And the clinical flavor, the approach, and the historical approach was amazing. So I'm sure we have lots of things to discuss at the end of this session. I'm very grateful for a very fascinating talk. Thank you very much. So we have the second speaker, Tope, who is going to talk about network approach to liver cirrhosis and acute liver failure as well as liver cirrhosis. Of course, now that we know that we are convinced by an expert clinician view that, of course, cirrhosis is multisystemic and liver plays a role, of course, a very important role. So I want to introduce Tope. Of course, you already know Tope as the other organizer of the meeting. So it is my pleasure to introduce Dr. Tope Oyelade. Tope is a lecturer in public health at the Keele University in the UK and also a research associate at the UCL Division of Medicine. He has a decade of experience in higher education teaching and research with a focus on data science, public health, and medical education. So he holds a PhD from the UCL Division of Medicine, specializing in the application of network physiology in liver disease. With expertise in big data analysis and evidence synthesis, he has published numerous highly cited papers promoting evidence-based medicine, which is really important for, of course, advancement of science. Evidence-based is amazing and important. Tope has developed novel methods for prognosis and survival modeling in patient with liver disease. He has a special interest in using routine clinical data to map physiological networks, an approach that has shown great promise in real-world clinical application. As one of the other organizers of this webinar series, Dr. Oyelade will be speaking today on physiological network mapping in acute as well as chronic liver failure. Tope?
Thank you very much, Ali. I'll try to share my screen. Please let me know if you can. Just one moment. So can you see my screen, Ali?
Yes, we can see the screen, although it's not a slide show at the moment. Yes, perfect. That's a slideshow.
Fantastic. Yeah, thank you very much. Yeah, so thank you very much, Professor Sara Montagnese, for that extensive chart about the clinical ramifications of liver disease. I'll be building most of my talk on what you've just said, essentially looking at how network physiology can help us in terms of improving prognosis and providing information about what is the best way to treat patients with liver disease. So the outline of my talk is as thus. So the first part of my talk is going to look at the liver as a central hub. I'll try to make that as fun as possible, if possible. And then I'll talk about acute versus chronic liver disease. And then I'll move on to look at the limitations of current paradigm, the paradigm specifically for prognostication in both type of diseases. And then, of course, I'll sort of bridge my talk on things like targeted treatment. And then, of course, the population level physiological network mapping, I will discuss that. I will then move on to discuss individual level physiological network mapping, specifically focusing on the use of paralytic network analysis, which we've used extensively in our lab. And then, of course, how we've applied it to acute versus chronic liver failure. And then I'll summarize, and then we can look at the future direction. So I'll crack on now. So I hope I can move forward. So why the liver? I think already I don't need to argue too much for the multisystemic involvement of the liver. But I would just like to say that, as Sarah's just mentioned, that the liver essentially has a slice in every physiological pie in the body. Essentially, it's part of one way, directly or indirectly, most of the physiological mechanism in the human body. Essentially, that's why we like to say, or I like to say personally, that once the liver goes, that most organs actually follow. Essentially, again, just to highlight that, if you can see this image, those are the essential implications of liver failure, essentially. Of course, the hepatic encephalopathy, it's one of them, which Sarah's extensively discussed. And then, of course, the variceal bleeding, hepatopulmonary syndrome, and the rest of other implications that sort of ensue once the liver essentially fails. And I'd like to include this slide about the historical understanding of the centrality of liver in the physiological map of the body. And I don't know, for some of you that are interested in Greek mythology, I don't know if you've heard about Prometheus, specifically the torture of Prometheus. Again, Prometheus, just as a brief summary, was one of the gods that lived on Mount Olympus. He was responsible for stealing the riddle of fire and giving it to man. Fire, if you don't know, in the Greek mythology, represents enlightenment, education, and research. So as a punishment, Zeus asked him to be tied to the side of the rock. And to punish him, Zeus sent his eagle to come every evening to feed on Prometheus's liver, so that the liver can grow again overnight, and then the eagle comes every evening to feed on his liver. I think what I want to highlight here is that as far back as in the era of Prometheus and Zeus, it is understood that liver is one of the most essential part of the human body. And I also want to sort of highlight that I believe that liver is about the only organ in the body with that regenerative capability, which I'll assume that evolutionarily would have been attributed to it because of the centrality of it to other organ systems. So enough of that about Greek mythology. Of course, again, the end of the story essentially ends when Heracles, also known as Achilles, came to kill the bird, and then, of course, set Prometheus free. Several centuries later, the birds that was used as punishment is metamorphosized into various other risk factors of liver disease. Such risk factors, which Sarah has mentioned as well, include unhealthy lifestyle in the form of maybe excessive drinking over a long period of time. And then, of course, paracetamol for acute liver failure. And then, of course, viral hepatitis, which I didn't show here. Just to highlight that, in fact, for acute liver failure, paracetamol poisoning remains one of the major drivers of acute liver failure. We're looking at up to 70% in developed country, essentially. So over the years, over the decades, I guess the idea is going forward that as scientists, as hepatologists, as researchers in the field of liver, we are still looking for Achilles, which is a way to sort of resolve the issue with liver disease. So, in essence, I'm trying to move this out of the way if I could. So, in essence, what differentiates acute from chronic liver failure, it's based on the time, essentially. Acute usually takes days to weeks to develop, while chronic liver failure might take, in some cases, up to 33 decades of constant and incessant insults to actually develop. And then, of course, for the chronic phase, what usually herald in the essential complications, which is characteristic of decompensation in cirrhosis, is what we call the decompensation stage, which is characterized by things like variceal bleeding, portal hypertension, etc. So once the liver then fails, what happens? Like Sarah mentioned in the previous slide, what usually happens is we usually either manage some of the decompensation in the patients by treating things like the Patorena syndrome, or treating potentially finding solution to all the other complications, or finding definitive treatment. So once liver fails, the definitive treatment is liver transplantation. And of course, because usually what we find that more patients needing liver transplantation than actual liver that is transplantable being available. So usually what we do is we need usually to prioritize the patient for such liver transplantation. And we use various models to do this. Now, I'm not going to dwell too much on this because Sarah's already mentioned about some of the diagnostic tools. But what I wanted the reason I wanted to show this is to look at some of the history of where we've gone, how we started, and where we are currently. And of course, this does not cover all of the different models that we have used and we currently use as well. So from 1964, the 1960s, when the child pool score was developed, until probably 2019, when the Med Plus was suggested by Oliveira et al. What we've noticed is we've gone from probably around 4 to 5 different variables to, I think, 8 to 9 variables currently, and some other more variables that people are starting to suggest. The point being, the more we know about the pathophysiology of liver disease, the more we realize that it is a multi-system, a multi-organ issue, and then being able to involve some of this organ in a prognostic model might improve it essentially. And in that line, I think that's where the network physiology sort of comes in, which I would sort of discuss probably later. So here I'm going to talk about some of the limitations, which you may have already figured out. From child's poo to MELD and Med Plus, and even the CLIF score, which was recently used for patients with acute liver failure. The trend has been the inclusion of more variables. Now, the problem with that, there's no problem with that actually, but the problem is essentially the way we see it is that most of these variables are still considered as independent units without any interaction. And of course, we know that this is not true. Some of these functionalities or the variables that represent them are interconnected in a very complex network manner. So prediction of specific treatment outcome is visibly missing in some of these general paradigm of prognosis or models that we use. So in terms of treatment, targeting single, also there's certain limitations that have become far more obvious as well. We've realized over the years that targeting some of these single decompensatory pathways increases risk of other complications. So instead of, so for instance, if patients develop hepatorenal syndrome and would decide to treat probably hepatorenal syndrome using vasoconstrictor like taliprosine, we realize that targeting these specific pathways essentially often lead into various complications. So for instance, the use of nitric oxide, for instance, for the inhibition of to regulate so nitric oxide inhibition, for instance, to regulate hyperdynamic circulation, which is sort of related to portal hypertension, have been shown to be associated with increased risk or to increase the risk of mental deterioration. We've also seen that using tips as well, like Sarah mentioned previously, has often been complicated by an increased risk of infection and, of course, hepatic encephalopathy, because it's associated with more ammonia escaping or making their way into the general systemic circulation, and then, of course, get into the central nervous system. Recently as well, we've looked at things like the use of albumin and terlipressin for kidney dysfunction. Various studies have shown consistently that pulmonary edema, the risk of pulmonary edema is also increased when patients are treated specifically for kidney dysfunction. Another study recently, in the entire study, they found that increasing albumin, which is because usually albumin is it's produced in the liver and generally reduced the level of albumin, serum albumin, in patients with liver disease is always usually reduced. So the idea is increasing albumin might, so the hypothesis was if you increase the albumin in circulation in patients with the compensated cirrhosis, that you might be able to improve outcome. But also that has shown that improving or increasing the albumin in circulation is associated with pulmonary edema. So, equipped with all of this information, we set out on a quest in our physiology, network physiology lab. And the question that we wanted to ask, or that we asked, was, can network approach, given all this information on the addition of all these extra variables and the fact that they've been considered as isolated unit, can network approach, which brings everything together and sort of look at the interaction between some of these variables, can it help to resolve some of these limitations or all of it? So to do that, we applied a network approach, right? So first, we looked at 777 patients with decompensated cirrhosis. The data source was from the entire clinical trial. The entire clinical trial was primarily aimed to look at the clinical beneficial effect of targeted albumin infusion. And the idea was to see if increasing albumin infusion to about 30 grams per liter could improve, which is higher above what you would expect or what is naturally given as standard treatment. Will this improve or reduce the risk of, say, for infection, or increase patient or improves patient's outcome in terms of mortality and in terms of infections as well. These patients were recruited across England, Wales, and Scotland, and they were followed up for 6 months. At recruitment, the clinical and physiological and laboratory variables were taken. And then, of course, we subjected this population to network analysis. So primarily, when we do a network, specifically before we do the parentage network analysis, we did a population-based correlation network analysis. So this is essentially based on, for some of you that attended the lecture given by Emily Ito, a very good friend and colleague, you will have understood specifically how the correlation network analysis was performed. Essentially, we looked at all of these variables, look at pairwise correlation between them. So we look, for instance, for the whole population, grouped by survivor, and then we sort of mapped the correlation between individual variables that were taken at baseline. So we look at, say, for instance, the sodium level and the heart rate. Is there any correlation between the survivors within the survivor group? And do we find the same correlation between the non-survivor group? Again, this is based on the whole population. And what we can see initially is that in those that survived after 6 months, on the population based, we saw an overall higher correlation network or higher correlation between the variables compared to those that didn't survive after 6 months. Of course, what this tells us is there's interaction on the population level between some of these variables. But again, like we already mentioned in previous talk, some of this is because this is population-based, it doesn't cater to the individual patient. So what we wanted to do, the aim was to see, can we map this physiological network for individual patients? And that's why we've used the parenchytic network analysis, which for those that didn't attend the previous section, allows us to be able to look at the specific correlation network, the network mapping for patients on the individual basis. So how does parenchytic network analysis work? So essentially what we do is we take all of these variables, we group the patients into survivor and non-survivor, and we use the survivor because our aim is to prognosticate for 6 months. we use the survivor group as the reference group because, again, the survivor is our aim in this instance. So, so if we take all the biomarkers, say for instance, sodium, and then of course maybe the pH of all the survivors, and then we plot that against each other, we find a sort of, and we take the R, which is the gradient. We build our model on that because, again, survivor is our aim. We look at the relationship. So this is, we built a sort of expected relationship between those biomarkers for those to survive. And then we then go back and then we bring individual patients, irrespective of their survivor status, and put them on the model. And then we'll see how deviated they have from individual. If we, for how deviated they have from the expectation in terms of the model for the biomarkers. Now, if we do that for all the biomarkers, what we get is a parenthetic network map that represents individual patients' sort of deviation from the expectation, essentially. And then we can then use that, whatever variable we get from that, we can use that to sort of do more statistical analysis to assess whether parenthetical network deviation or the deviation from expectation is associated either with survivor or with treatment outcome. For further details on some of those, the methodology, you can look at some of our studies. There was this study that was published in 2023. I'll move on. So for this specific study, after the parenthetical network analysis, what we found was quite interesting. So aside from the fact that on the population level, we saw that 6 months survivors, those that survived after 6 months, had an overall higher connectivity between the variables. We also found, in terms of parenthetical deviation, we found some very unique study findings. So, for instance, we found that for patients that did not survive, they had a higher deviation along the inflammatory pathway. So specifically, the coordination between the white cell count and the C-reactive protein was pronounced. And this essential deviation we found was associated with increased risk of mortality, 6-month mortality. Specifically, we found that for every unit deviation along this axis, there's 11% increase in the chance of 6-month mortality. And then, of course, we found that white cell count as well, the bilirubin axis was also associated with about 6% increase risk of mortality. And again, this is just to also mention that this mortality prediction was found to be independent of MELD, which was at the time of the analysis was the standard model that was used for prognostication in these patients. So we went ahead and did some further statistical analysis using the parenthetical deviation, the parenthetical indices. And then what we found, we also used the parenthetical indices to see, can we, so another question that we asked was, can we use parenthetical deviation or parenthetical network analysis to be able to tell, for instance, patients that are likely to benefit from the increased albumin infusion, which was primarily the aim of the entire study. And what we found was also striking. We found that specifically that patients with increased deviation along, say, the inflammatory biomarkers, that's the white cell count CRP axis, were least likely to suffer any complications. So essentially what that means is, in terms of pathophysiology, the patients that had least deviation along the white cell count CRP axis actually did not benefit from increased or targeted albumin infusion. And think to drive that point home, I think this figure essentially drives that point home. And the idea was for those patients with intact coordination between the white cell count and C-reactive protein, that is those patients that have more coordinations between these had higher mortality after 6 months compared to those that did not have that coordination. So essentially, what we could translate that as is that having maybe increased albumin, and this is maybe increased or targeted albumin infusion, actually disrupt the coordination or the acid or the coordination or the network connections between white cell count and C-reactive protein. So, so that is for chronic liver disease. So we moved on to assess, we also asked the question for chronic liver disease, which takes so many years. Of course, that years, essentially, some of it will be devoted to probably, or some of it will go to, they have more time for some of these complications or some of these uncoupling of some of these variables to happen. What happens when we apply this method in patients with acute liver failure? So those are patients probably essentially with paracetamol poisoning, so paracetamol overdose. And usually what the difference is essentially these patients between the incidence of the paracetamol overdose and when they actually develop the liver failure, they have a very short period of time in terms of clinical history. So what we did was to extract 640 ICU patients with paracetamol-induced acute liver failure. The data source was the MIMIC-3 data source, PhysioNet, and then they were followed up for 28 days, which is about the average time that most studies have used for prognostication in patients with acute liver failure. Again, the reference group in our situation is also survivor. But before we did the parenchymal network analysis, we also did a correlation network analysis for the patient. And what was striking again is that overall, based on correlation network mapping, patients that survived had an overall higher connectivity or higher coordination between the variables compared to non-survivor. But aside from that, we did what we call the clustering analysis. And the idea was to look at what are the clusters of variables within the overall network. So which variables are closely related to each other compared to other variables within the same network. So the idea in this case would be that, for instance, INR and AST in the survivor is closely related or has higher coordination among themselves compared to maybe other other variables within the same network. And what we also found was striking. We found that, for instance, specifically that pH in the non-survivor group is far more related to bicarbonate and SpO2. And for those that survived, we found that their pH was far more related, especially in acute liver failure, far more related to their kidney function, like creatinine. So what is the implication of this? So again, our result essentially shows overall network connectivity higher in patients that survived after 28 days. For the clustering analysis, we found that pH regulatory pathway differs between the group. Specifically for those that survived, the pH regulation is far more closely related to their kidney function. Why? For those that did not survive, their pH regulation is linked to their respiratory functions. Other findings include that the parenchymal deviation along the pH creatinine specifically as expected, and pH bicarbonate, lactate, glucose, and lactate heart rate, as well as SpO2 and respiratory axis, were also predictive of 28 days survivor in this specific group of patients. And this survivor prediction or prognostication was independent of the current variables or the current models that are used for prognostication in these patients. That's the King's College criteria and the SOFA score. That's the sequential organ failure assessment scores. And of course, we did Kaplan-Meier analysis to see how the patient fare across the follow-up time. And as you can see as well, compared to SOFA, we did see an improvement in terms of combining some of our variables, because the aim was not to essentially cancel what the model is used. I think we'll find it hard to convince clinicians to drop the model that they're using compared to telling them that adding parenchymal network indices to the current model might improve. So what we found was an overall improvement in the prognostication of some of the standard models that were used or that are currently being used when we added some of these parenchytic indices. Of course, aside from using just mere Kaplan-Meier curve to be able to see the improvement, we also use IDI and NRI, which is net reclassification index. So these are main statistical index that are used to assess improvement in prognostication. And we also see statistical significant improvement in prognostication when parenchytic network analysis results were added to the current model. And this applies and this holds true when we did the same for the MELD as well. So in summary, after all of this study, what we found was that network physiology approach offers new insight into not just prognostication, but the pathophysiology of liver failure the current model lacks. It can also predict survival and improve current prognostic models. It detects pathophysiological switch, driving prognosis in liver failure. So again, we can see that we can detect specific axes in the physiological network that are contributing to, say, prognosis, for instance. And then, of course, what that means is we can specifically target those. It can also predict treatment outcome. Again, we can specifically use some of these axes that are important in the treatment response, and then we can use them to specifically design personalized and targeted treatment. So what are the future direction? The future plan is to validate a multinational population of patients because, as you may well have noticed, some of these populations that we've used, one of the limitations is that they're usually from either from the same country or from single center like the ALF patients. So we would like to validate this in multinational population patients. We're also planning to assess network dynamics across different time points because, again, we've used the variables that were collected at baseline for our analysis. So the idea is, how does network map? How do they change across time? So for instance, maybe 24, 48 hours after the patients were taken in or admitted. And how this evolves and what insight could the evolution offer. We also hope that we can assess network physiology using reliable continuous recording. So this is the idea of using transfer entropy in prognostication in cirrhosis or other groups of liver failures patients. Also, the overarching aim would be at some point in future for us to be able to have maybe a sort of hub or an integration that would tell us across time the real-time network physiology map of individual patients so that this can be used to guide clinical decisions. So while we're still looking for Achilles, we're hoping that the opportunity offered by the network approach, it's exciting and it's going to offer more outlook or more insight in future. Thank you all for listening, and yeah, that's the end of my.
Many thanks, Tope. Thank you very much. Very, very interesting results and very promising. Hopefully in future, of course, the validation will help and can be used probably or tested in future clinical practice. And of course, we can understand why we have this type of interaction, how we can assess them better. Thank you. Very, very interesting talk. So we have time for question and answer. So basically, I want to ask the audience, the attendees, please, if you have any question, please type in the chat box and then we will discuss them. While you are, of course, thinking about your question, I have a few questions from our excellent speakers. If I may start with Professor Montagnese. Sara, can I ask you a few questions? So the first question I've got for you is, so you mentioned about all of those very interesting complications. As a doctor who are dealing with patient with liver disease, cirrhosis in your daily basis, how much time you spend on targeting their liver and how much time you spend to support other organs that are involved in patient with liver cirrhosis?
Well, it really, well, it depends. Targeting the liver by itself, virtually zero time. By the time a patient is in hospital, for inpatients, virtually no time, unless they have liver cancer, is directed at imaging, studying. I mean, if we think about it, what we call liver function indices are not even liver function indices. I mean, Danish old physiologists would tell you that nothing of what we have in Child-Pugh, MEL, whatever, are actually liver function indices. And we are still very much struggling for that. So the truth is we do mostly support other organs. And we also, something we didn't mention, but Tope's talk made me think about it, because that very interesting relationship or lack thereof between white cell count and CRP, I think brings in two big topics. One is infection, which we haven't really mentioned, but it's the big driver of whichever way the compensated patient goes towards, and how complications develop. But also it brings in an additional layer, because both in patients with and without cirrhosis, very often the patient in whom infection is suspected is admitted for white cell count increase. And over the next few days, you see CRP increasing. And in whoever you measure procalcitonin, that also has a different dynamic. So I was really wondering, although I'm turning the question to me into a question for Tope, if even over a very brief period of time would bring an additional layer into this relationship and into the network itself, it would seem very relevant to me.
Thank you. Very, very good question. So the question is, so when we are looking at biomarkers such as white cell count and CRP, so then the time, do we need to include time? How long does it take? Do we need to include the data? It's dynamic to the equation. Is it a question? Okay, but that's a very good question. Tope, do you have any comment about observation of CRP and white blood cell? Just for our audience who don't know what CRP is C-reactive protein. It is acute phase protein that is released from the liver when there's inflammation or infection, right? So then white blood cells count is the number of white blood cells that we see in the blood, and they are both measured as sign of infection. So that's a very interesting question. Very good. Tope, do you have any comment on this question?
Yeah, no, absolutely. I think I'll just add a little bit of, I'm not sure if the answer is going to add more complexity or it's going to, but the idea is, I think some of the literature we looked at when we were drafting the paper, essentially, what we realized is what we actually found is not absolutely new. That, like you said, Sarah, that some of these observations are things that you would see in a clinic, and it's just being able to quantify it. So I think one aspect of the complexity which I was going to bring up was the fact that, so for instance, if we take CRP, for instance, we look at CRP in patients with cirrhosis, when they come into the clinic, it's going to be already low because their liver is absolutely gone anyways. So using CRP in itself, again, it comes to sort of link it to the idea of network connection. So using CRP itself as a marker of probably prognostication might not be sufficient enough. And that's where the extra complexity comes in, because it might be the interplay between that itself and how it's able to maybe initiate other inflammatory biomarkers that is actually playing into how patients are likely to survive. I'm not sure that answers your question, but in the idea of how it changes over time, I think one of the questions that we've gotten over and over again is maybe what we're looking at it a bit wrong or is too early. But the idea is we're looking at some of these results that we've shown in terms of network physiology and network physiology at admission. And this might not give us the overall picture, because what if we're able to sort of look at how the dynamics of the network changes across time? And this could be, for instance, for the CRP and WCC, or it could be for other variables that we've actually seen that are contributing to the prognosis. So how do they change 24 hours? How do they change 48 hours? And how is that change, that dynamics? How do they sort of link back to how likely a patient is going to survive? I think That again might add a little bit of complexity, but it might be able to give us far more insight in terms of the clinical history and what is going to happen in the next 2, 3, 4, 5 days. And that insight might be able to give maybe advice what's the best approach to treat such patients. I don't know again if I've answered the question.
Is it possible? Can I combine both those comments and answers? So I take from the excellent question and excellent comment is that, so if we look at the time series of CRP and white blood cells, so we can actually look at the interaction in a network much better, and time matters really, because the dynamic of change of CRP and white blood cells is different. At this moment in time, we have a snapshot of data, so we don't know, we have the time, so we don't know, we cannot answer the question based on the data. But there is something very interesting. So the way that I can see that Tope has explained in his papers about CRP white blood cell is that we expect for someone who has a compensated physiology, when white blood cell go up, CRP goes up as well. So when we have this correlation, it means that at least at this axis things are okay. When there is disruption, white blood cell is up but CRP is down, or vice versa, it means that there is something wrong with this connectivity. And of course, that has shown some promise in predicting who might respond to target albumin therapy. But I take this point that hopefully, I don't know, in maybe not in next 5 months, but in a few years, we will have data from time series to be able to answer this question based on evidence. Thank you both. I have more questions for maybe a question which I want to ask both of the speakers, but it is a little bit about, but maybe I start with Sara first, because of Sara mentioned about history as well. So of course, my question is, so when we think about decompensation, it's a very interesting topic for someone who is not expert in liver disease or someone who is just trying to understand physiological system. So we need to have a definition of what happens from a system which is compensated, and then something goes wrong. Then we have the compensating mechanism leading to, I don't know, deterioration or death, etc. My question for Sara is, first of all, so how do you define compensation, decompensation? Is it clinical diagnosis or is it based on physiology? And secondly, do we know when this terminology, compensated, decompensation, came to medical practice within the context of cirrhosis?
In many ways, it's a very simple, and in many ways, it's a very difficult topic, because I have used for purposes of the lecture and my reasoning behind it, relatively old-fashioned definitions of the compensation, the terminology around cirrhosis and its complication has changed a lot, and continues to change. I mean, there is papers on end to be read on hepatology journals over the past 4 or 5 years on how you define what. I think that the mobility of definitions and the fact that they are all either completely clinical or based on movable thresholds betrays our inability to understand the pathophysiology behind it. So there is a need to call people compensated or decompensated, because we know it affects prognosis, and because we know there is these two situations in which we see different things. To me, moving the scales and the thresholds and making more classes, fewer classes, or whatever, until we understand. Of course, we know, for example, that if people get an infection, that's a big driver. Moving one person, even temporarily, from compensated to decompensated. But calling it decompensated still depends on what you see. And it still depends on them needing to access the services, them needing to be admitted. For example, for hepatic encephalopathy, which is my own field, we have come to consider that admission over time are very relevant outcomes, because in the mid ranges, we don't know what's happening. And so it's easier to use harder outcomes and clinical outcomes. So I think that unfortunately there is little pathophysiology still into all of this.
Thank you very much. So okay, so that's all. Clinical definitions are, of course, based on insight of the doctor, which is interesting, maybe not easily transferable. Of course, someone experienced like you, of course, have much better, the network in your brain is better for diagnosis of someone, but at some point, of course, we need to be able to quantify it. The same question for Tope. So Tope, have you seen any network mapping to compare decompensated from compensated based on current clinical criteria? Or such as, the methods, such as pancreatic deviation or any other method? Can I ask if you have seen anything like that, or can you comment on how we can use network physiology to find the transition from compensation to decompensation?
Thank you very much for that very good question. I think I haven't seen any study. I think, of course, I'm looking at some of the challenges that might present, because I'm not sure that patients usually present to the hospital unless they have a decompensatory event. So in terms of capturing patients before they actually, I think it's a age-old question, I think, in hepatology. I'm not very sure, but I'm assuming that usually before the decompensatory event, which is either variceal bleeding or any of those complications actually shows up, patients are usually assuming that they're fine. But then until they start showing some signs before they come, and usually by the time they come to the hospital to show signs, when you can actually capture them in terms of study, it's probably too late by then. So it will be interesting. It's based on some of the insight that we've seen using network physiology. My best guess would be that, yes, we should be able to see that physiological change being detected using physiological network approach. But whether we'll be able to get our hands on patients before and after they develop that condition, I think it will be the holy grail of network physiology.
I understand that you're talking about the practicality of that kind of cohort that actually have follow up, and I agree with you. But so maybe hopefully with using wearables, technology, etc., we might be able to have some, or maybe what if we use, I don't know, some big cohorts that are running at the moment, and we can get some data for future. That is amazing. So I'm a bit conscious of time, and I want to show a few slides. Just a very quick questions for our speakers. So then just Sara, for you. So you are expert in hepatic encephalopathy, but of course, the nervous system is not just the cerebrum. So do you consider all of the problem with, for instance, the circadian abnormality part of the syndrome of hepatic encephalopathy, or you think they are very different? Or can I ask this question? Because you're expert in both fields.
Yeah, I think that's a very relevant question, in the sense that circadian abnormalities in people with liver disease have been studied with a view to understand sleep-wake abnormalities in patients with liver. Since then, we have learned many things. Well, on one aspect is for sure, and it is well demonstrated, is that ammonia itself in animal models can change the amplitude and the timing of the central circadian clock oscillation. So I think that hepatic encephalopathy being linked to circadian timing production is kind of a yes. But since we started doing this in liver disease, we've learned that there is a liver clock. We learned that the liver is the place where the clock timing system and metabolism talk to each other. We've learned that if the muscle clock is disrupted, a network of peripheral clocks driven by the liver stop functioning. So I would say that the answer is yes and no, that there are aspects of hepatic encephalopathy that for sure impinge on both central and peripheral circadian timing, but I think there is also a big component that is cirrhosis per se.
I love the way that the whole network works. It was very interesting answer. Thank you very much. Lots of, I'm sure, papers and discoveries will follow your interesting comment. And a very quick question for Tope. Tope, you have done, apart from what you do in data science and physiology, you do lots of systematic reviews, meta-analysis. So then, have you seen any systematic review in network physiology? I guess it is something that is missing, because in clinical field, we do lots of systematic review to make sure that we don't have bias of our own ideas that we have to work for years and years. But is there, I want to ask you, because you are expert in evidence-based medicine, is there have you seen any systematic review on the topic related to network physiology?
Yeah, sorry, I'm going to disappoint you. I haven't searched lately, but
Okay.
I haven't. But the last time I searched, there is none, because again, this is a developing field, and I think there's only a handful of us working in the field. But I absolutely agree that you're right. Once the studies start to come in, there will be a a systematic review, probably either by us or other groups. I know that people with John Hurst and the guys at the respiratory at UCL, they've looked at potentially some of the approaches that have been used essentially in quantifying sleep related to some of this physiological approach. But I haven't seen any systematic review specifically on the topic of network analysis in liver disease. So no. I think there's some questions in the chat as well.
Yes, thank you very much. So basically, I'm very glad that Professor Ivanov is here. So there's a general comment on application of transentropy measures to derive dynamic network. So there might be some, of course, problems that we need to consider. Time scale, potential therapeutic effect on non-stationaries embedded in visual signals. That's very important, of course. And the limitation to probe interaction across time scales, of course, and consistency to finding across patients with same diagnosis. Thank you very much for these comments. I agree, and of course, we have to consider those limitations and address them in future studies as well. Thank you, Professor Ivanov, for attending, also for this excellent comment. So,
sorry, I think Emily has another question.
Emily, I didn't see that. Apologies. Emily, a question. Okay, thank you, Professor Montagnese and Dr. Oyelade, for the amazing presentation. I have a question for the panel. It was fascinating to hear about the potential of network physiology approach in predicting mortality and response to albumin treatment. I was wondering if there is a potential of network physiology approach in predicting development of liver disease related to conditions such as hepatic encephalopathy before patient develop it. Okay, can we use network physiology to predict development of hepatic encephalopathy? That's a very good question, Emily. Thank you very much.
Thank you very much. I think there's potential. If there's an outcome, then it can be predicted. I mean, I'm talking like a statistician now. So yeah, if we have the data, definitely, I think it is possible. Whether we're going to get a positive predictive, whether it is actually going to predict it or not, we'll leave that to when the study is actually done. But there's potential to be. If you can group it, yes, you can predict it.
But may I add, you're not talking like a statistician, you're talking like a clinician, because you started by saying if there is an outcome. And I think the big caveat is that we are still bad at defining the phenotype. There is still a lot of disagreement on what is called hepatic encephalopathy. So the outcome, again, may need to be a hard outcome, admission for hepatic encephalopathy. So something so brutal that by the time you're there, probably this may or may not be important. We have to become better at profiling before we can try, I think.
Absolutely. That's true, definitely true, definitely. So I want to thank the speakers, Sara and Tope. I'm very grateful to you for your time and excellent discussion we had. Of course, we are a little bit short of time. I just want to wrap up with just couple of slides. I hope you can see my screen. So, okay, so basically this is if I want to summarize the whole series of 4 series, I took this slide from Emily Ito, who gave a talk yesterday. So I think that was so interesting. It maybe summarized everything we discussed in the last 4 sessions. So of course we shouldn't look at these organ systems individually. We should look at how they interact. It doesn't mean that the methods that are available now are perfect. Of course, we have to develop new methods. We have to collaborate. And because it's an emerging field, I think it is very exciting, because I have seen, at least from our side, undergraduate students coming, recent graduates, they contribute because it is open to so many developments. So it is not like a very established discipline that takes, it is very difficult to really find an open space. So it is open space to develop and to collaborate with many very good people. You see, whenever we have clinicians in this talk, we have very nice insight. When we have scientists, we have excellent insight from the other angle, and they complete each other. So This is there might be one slide from one of our excellent speakers to maybe sum up the series. So there is, if you are interested in network physiology, our series was a little bit, of course, overview with clinical touch. But if you want to, if you are interested and you want to attend a meeting at school, face-to-face meeting to talk to the experts and have more in-depth, of course, view of the field, I suggest you register and come to COMO. That, of course, our colleagues and pioneers of the field are running, and I'm sure it will be a fantastic, of course, opportunity. I want to have a thank the speakers for excellent, all the speakers, excellent talks. And I'd like to thank the event organizers. So they have made everything so easy for us and everything so organized. I want to thank Abby, Simon. They every day in all of meetings, they came early. They provided everything, which is really good. And also Caitlin and Sarah, that we initially talked to them, and they made everything much perfect for our work. So I don't know what time is it. Probably it is. Of course, we don't have that much time. So thank you all, and I hope to see you in face-to-face or in other webinars. And I hope we collaborate with all of you. Thank you very much.
Thank you very much, everyone. Thank you.